Bismillahirrahmanirrahim. I welcome all of you on today's session of gastroenterology and hepatology related lectures. I'm Professor Shahid, working as Professor of Medicine and Gastroenterology at Allama Iqbal Medical College. Today we are going to discuss how are we going to approach a patient who has presented to us with retrosternal discomfort. Now let's start with case history. 45-year-old man who has presented in outpatient department with retrosternal discomfort for the last 2 months. The very first thing that should prompt up in my mind is the differential diagnosis that I'm going to think of in this particular patient. Now that differential diagnosis, at the top of that list, I think the first thing that I'm going to think about is ischemic heart disease, because he's a patient of 45-year-old age and he has presented with retrosternal discomfort. Apart from that, there are possibilities like gastroesophageal reflux disease. I'm also going to think of eosinophilic esophagitis. Then obviously, less likely possibilities are like aortic dissection. There are motility disorders of esophagus like diffuse esophageal spasm, which presents as retrosternal discomfort or retrosternal pain. Then costochondritis and things like that should also be considered while dealing with a patient of retrosternal discomfort. But top of the list are two possibilities. One, ischemic heart disease, the other, gastroesophageal reflux disease. The rest one are there, but they are obviously not that common as the first two one are. So the first thing to understand is what questions should be asked from a patient who has presented with retrosternal pain. Now, this is the list of questions. I'm going to ask that the pain is intermittent or continuous. Is it a tightness, chest tightness, or a pain? Does it radiate to arm, neck, or back? Is there any associated sweating or diaphoresis? And I'm also going to inquire about aggravating and relieving factor from this patient. Is there any association of this pain with the meal? Is there any history of regurgitation of food contact? And obviously, I'm going to talk about the exertion leading to aggravation of pain on that. And you can understand on the background of all these questions are those differential diagnoses that I'm thinking of: ischemic heart disease, GERD, and other possibilities. Now, what will favor ischemic heart disease? If the pain is intermittent, if it is more of a tightness, if it is associated with sweating and has got some form of radiation, or is it aggravated with exertion, or there is any history of shortness of breath as well. And obviously, I'm going to ask about the risk factors for ischemic heart disease, which includes hypertension and diabetes. If these are the features which I will find in a patient with retrosternal discomfort, I will think more of ischemic heart disease. But if this pain, retrosternal discomfort, is more of burning, if it is associated with intake of meal, is there any history of regurgitation of food content after taking meal? Or patient tells me that he feels bad, he is having bad taste in mouth all the time, or especially early morning, or there is dryness or bitter feeling in the early morning, or patient is suffering from nocturnal episodes of chest pain, I will think more of gastroesophageal reflux disease. So that's why it is important to have a detailed clinical history to guide you regarding the diagnosis. So coming back to our patient, he complains of burning for last 2 months. It mostly follows the meal. He also complains of foul smell in the mouth, especially in the morning, and he needs to get up at the night because of this discomfort and history of burns. The next question is, these symptoms are very typical of gastroesophageal reflux disease, but should I get an ECG in this patient? I will consider his age and presence or absence of risk factors in this patient before making this decision. Why? Because ischemic heart disease pain can be associated with the intake of meal. Ischemic heart disease pain can be burning in character, and obviously this can be a nocturnal episode as well. So we had an ECG of this particular patient in the emergency setting, which was perfectly normal. So most likely diagnosis in this setting will be gastroesophageal reflux disease. Now, what is gastroesophageal reflux disease? And whenever I talk about this term, then there is another term which is NERD, non-erosive reflux disease. So by definition, gastroesophageal reflux disease is either a symptomatic condition or it's an histopathological alteration resulting from episodes of reflux disease. So majority of patients who presents with symptoms of gastroesophageal reflux disease, they don't have much of findings on endoscopy. So they are labeled as non-erosive reflux disease. While those who have got erosions or ulcerations on endoscopy, those are typical cases of gastroesophageal reflux disease. But you can understand that this differentiation of GERD and NERD is only possible after endoscopy, not before that, because symptomatically it's going to be the same patients. Right. GERD is equally common in males and females, but somehow Barrett's metaplasia, which is basically a complication of long-standing GERD, is more common in males, much more, with a ratio of 10 to 1. Now, the next question is why patients develop reflux. We know that once the food passes through the esophagus into the stomach, there are a number of mechanisms which are present, a number of natural barriers which are present, which does not allow the content of the stomach to come back to the esophagus. Now, what are those barriers? There is a lower esophageal sphincter. We know if it is competent, it is not going to let food content come back into the esophagus. Then intra-abdominal location of the stomach and its angle that it makes with the esophagus, that also hampers the regurgitation or upward movement of the food contents. Presence of diaphragm, its crura, they have got their own certain pressure which impedes or which blocks the passage of the food content above the diaphragm through the esophagus. Then obviously esophagus is an organ which is continuously moving. There are peristalsis going on, and that keeps clearing esophagus of any acid, even if it comes into the distal part of the esophagus. Then we are all the time swallowing our saliva, which is basically alkaline. So that's another way of neutralizing the acid which comes back, if it comes back into the esophagus. And obviously movement of the stomach ensures that the food content that we have taken, that is not going to stay for a very long time into the stomach. So naturally, there are so many mechanisms which are controlling this reverse passage of the food into the esophagus. So what happens in patients who have got gastroesophageal reflux disease? Either the problem is within the esophagus, because we have already talked about these all factors of esophagus, which ensures that distal end of the esophagus is clear of the acid and is not exposed to the gastric acid. But in case of impaired peristalsis, if there is reduced salivary neutralization or impurities, impaired esophageal mucosal defense mechanisms, these can lead to precipitation. These can lead to the excessive passage of acid and stay of acid into the distal part of the esophagus. But most important factors are 2 or 3. One is incompetent lower esophageal sphincter. Another is hydersemia. And obviously, the third common responsible factor is increased transient relaxation of lower esophageal sphincter. We'll take 2 minutes to just discuss these important etiological factors in GERD. So if lower esophageal sphincter becomes incompetent, obviously what will happen is that the food can easily pass back into the distal end of the esophagus. And there are multiple factors which can lead to this incompetency in the distal lower esophageal sphincter, resulting in reflux of the gastric contents. The second thing that we talked about, which is responsible for development of reflux disease, is hydersemia. Hydersemia is simply the passage of part of the stomach above the diaphragm. It may be through the same opening through which the esophagus is coming down. In that case, it will be sliding hydersemia, or it may, the fundus of the stomach passes up into the chest. That is basically paraesophageal hydersemia, but it's the sliding hydersemia which is primarily responsible for reflux of the gastric contents into the distal part of the esophagus. Now, apart from these common causes, there can be diseases of stomach as well, which can result in reflux disease, like impaired gastric emptying, like raised intra-abdominal pressure, or increased acid pepsin production, or sometimes pyloric incompetence may result in reverse flow of the bile, and that may end up into the distal part of the esophagus. That can also lead to the same symptoms which are typical of reflux disease. So what we have seen is there are a number of mechanisms, there are a number of pathologies, number of alteration in normal physiological mechanisms which can result in reflux disease. But we need to remember that hydersemia, increased transient LES relaxation, and incompetent lower esophageal sphincter are the main main causes which are behind gastroesophageal reflux disease. So let's move on to the symptoms of reflux. Symptoms can be typical or it can be atypical. Typical symptoms are retrosternal burning, regurgitation of the food content into the lower part of the sternum, or patient comes to you with bitter taste in the mouth. That is mostly in the early morning when he gets up, there is bad taste or foul smell in the mouth. These are typical symptoms. So very easy to diagnose these people because symptoms are very typical. But we need to remember that patients with GERD can present with atypical symptoms as well. Sometimes they may present to you with recurrent gingivitis, with foul breath, with tooth degeneration, maybe regular ear ache. Sometimes these patients present with chronic cough, dry cough, or worsening of asthma, or recurrent lower respiratory tract infections. And you keep working on for why the patient is having this problem. So one of the possible causes is reflux disease, which needs to be kept in mind. So coming back to our original patient, 45-year-old man with retrosternal discomfort, and he was having these symptoms for 2 months. Let's talk about how to confirm this diagnosis. So I have got multiple options to confirm diagnosis. Either it's the symptoms which are suggested, then I can do an endoscopy, then I can do pH monitoring, then a modern form of pH monitoring, that is impedance pH monitoring as well. So let's see how are we going to use these tools for diagnosis. Remember one thing, diagnosis of GERD is purely clinical. If the patient has presented with typical symptom and you have excluded the other possibilities, especially ischemic heart disease that I talked about in the initial phase, then you can confidently make a diagnosis of reflux disease. And you may not need any test to confirm this diagnosis. So what about the role of endoscopy? Endoscopy is not to be performed in every patient of GERD. It should only be performed in patients who have got certain red flag symptoms, certain symptoms which are signs of danger. In that case, you will decide to perform an endoscopy. Now, these are those red flag symptoms. Patients with extraesophageal symptoms, patients with new onset symptom after 45 years of age, patients with anemia, dysphagia, weight loss, hematemesis, melena, or if you have given the treatment and patient has taken the treatment for 4 weeks and there is failure to improve, or GERD is there for last more than 5 years. In that case, because of some possible complications which are associated with long duration of GERD, you will proceed for endoscopy. So our patient is a 45-year-old man and he has got these symptoms for 2 months. Obviously, he needs to undergo endoscopy. Generally, there is a classification system which is used to describe endoscopic findings in patients with reflux disease. It's a Los Angeles classification. If the erosions are less than 3 millimeter in size, they are generally present at the distal end of the esophagus. So then you will call it as GERD class A. If these linear erosions are along the folds of esophagus but are more than 3 millimeter in length, you will call it as LA class B. If these erosions or the changes of reflux disease are extending beyond the folds in circumferential manner, but involving less than 75% of the circumference, then you will label it as C. And obviously it is involving more than 75% of the circumference of the esophagus, then it is called as the LA class D. So this is one way of describing the findings that you find on endoscopy. You do not take biopsy in a routine in a patient with reflux disease. Biopsy is only needed if we note some abnormality in mucosa, if we suspect that there is a possibility of Barrett's metaplasia. Obviously, then you will take the biopsies. Otherwise, it's a clinical diagnosis, which if the endoscopy is needed, it can be seen on endoscopy very easily. Histopathology is only needed in case of possibility of complication, especially the Barrett's metaplasia. We did an endoscopy in our patient and we found that there are linear erosions along the esophageal folds, and obviously the length of these erosions is more than 3 millimeter. Now the next question is, do I need to document presence of acid, excessive acid in the distal esophagus via pH monitoring? Obviously no. pH monitoring in reflux disease is only used in very selective situations. If you are planning for a surgery in a patient who is not responding to the treatment or is not willing to take long-term treatment, obviously there you need pH monitoring before proceeding for an intervention. Then obviously few other indications, but it's not something which you are going to do in routine. Simple thing to understand about pH monitoring is that you pass a probe into the distal esophagus. Now we have wireless pH monitoring devices as well, which are placed in distal part of the esophagus. They remain and it is left there for 24 hours. Patient is provided with paper and he is asked to note the time of his symptoms, and then also he has to note the time of his meal that he has taken during those 24 hours. And then you try to correlate that with the pH that has been measured on pH monitoring. Obviously, if the pH is less than 4, that is abnormal. That means that the acid of the stomach is coming back. So that's how you can diagnose patient to have reflux of acid into the distal part of the esophagus. So just to give you an algorithm, generally in patients with GERD, you always start with proton pump inhibitors. If patient is not responding, you optimize that treatment. If patient is still not responding and he has got typical symptoms of reflux, you will go for endoscopy. Either you will get an alternative diagnosis, then we will treat that, or that may be normal. Or you might find the changes typical of reflux disease. In that case, obviously, you have to move to the next option of treatment. If the symptoms are atypical, before proceeding to the endoscopy, it's better to have an evaluation by ENT pulmonologist, because atypical symptoms like cough, worsening of asthma, or regular earache, and all these, they need to be evaluated by the specialist as well. And if there is a disease in the related to other specialties, that needs to be treated. So, but if there is no other disease, patient has atypical symptoms, or he has typical symptoms with normal endoscopy, then you may need pH monitoring in this particular situation to make to confirm or verify your diagnosis. If the patient, there is high likelihood of having reflux disease, you don't need to stop proton pump inhibitors. But if the pretest probability is low, then you stop treatment for 2 weeks before proceeding for the pH monitoring. So that was briefly about how the pH monitoring is done. So one thing to remember, that the diagnosis is clinical, and endoscopy and tests should only be used judiciously where indicated. Now to the last part of our talk, that how are we going to manage these patients who have been diagnosed to have reflux disease. There are 3 cornerstones of diagnosis. 1 is lifestyle modification, 2 is medications, and 3 is surgery in selective situations. Lifestyle modifications, that includes a lot of things. Obviously, you advise patient to avoid caffeine and fatty food and alcohol. These are the food items which are known to be associated with higher acid production. Then smoking is one thing which aggravates symptoms of reflux disease, because with smoking, sphincter tone in lower esophagus, that reduces and that precipitates the symptoms. Then weight reduction reduces intra-abdominal pressure. That also will help facilitate the improvement of symptoms. And then you have to advise the patient to take at least dinner at least 3 hours before going to the bed, so as to avoid easy reflux or easy flow of the food content into the esophagus while he's lying down. Then patient needs to be advised to raise the head end of this bed for at least 6 inches. And that elevation of the head end is not through doubling the pillows. It has to be the elevation as has been shown in this picture in a slanting manner. So small meals, late night snacks needs to be avoided. And obviously you have to be selective what to eat and what not to eat. And this should be the posture of lying down if we want to take full advantage of this postural adjustment in relief of the symptoms. The drugs, the one drug which is used is proton pump inhibitors. Now, how that is going to help? That basically blocks the production of acid in the stomach. So that's not addressing the underlying causes. It's basically reducing the acid content in the stomach. That will result in lesser symptoms of reflux disease in these patients. So how do we use proton pump inhibitors? We generally start with the low dose. Then in case patient is not improving, we can increase it to from 20 milligram to 40 milligram, or we can increase it from once a day to twice a day. This treatment needs to be continued for at least 4 to 6 weeks. After that, if we have an endoscopy of the patient and patient was a case of non-erosive reflux disease, or there was only mild erosive esophagitis, then we can, after 6 to 8 weeks, we can change the patient to proton pump inhibitors on demand. Whenever he has symptoms, he can take the medication. But in case of severe erosive reflux disease, you may need to continue proton pump inhibitors for a longer time. And you will encounter patients who are taking these medications for years and years, because whenever they try to stop this drug, they have recurrence of symptoms. There is enough evidence to suggest that all types of omeprazoles which are available, they have very good healing rate in patients of reflux disease. And there is no question about this, that proton pump inhibitors are much better than H2 blockers in dealing with the symptoms of reflux disease. But when you are using proton pump inhibitors for a very long time, you need to be aware of the possible side effects. There are more chances of having infections, especially lower respiratory tract infections, and Clostridium difficile infection in patients taking proton pump inhibitors. Then you have to be aware of the possibilities of B12 deficiency or iron deficiency or hypomagnesemia that you may encounter. Patients also are more likely to have osteoporosis and fractures if they are taking these drugs for years. So try to supplement this drug with whatever is needed, B12, calcium, and these things if they are getting deficient. So let's come back to our patient. He was advised omeprazole 20 milligram once a day, lifestyle modification, dietary advice, and partial improvement, not full improvement. So here is an important catch to be addressed. That if patient fails to respond, what can be the reason? Despite having definite diagnosis of reflux disease, he's not responding to proton pump inhibitors. That the possibility can be patient is not complying to the medications. That is one possibility. Another possibility that I need to rule out is the possibility of functional disorders like irritable bowel syndrome or functional dyspepsia. So always go back to the diagnosis, always review your history and try to dig out if there is anything which is being missed in these patients. But remember, there are patients of reflux disease where the symptoms are not due to reflux of the acid. Maybe it is it's a bile which is refluxing into the distal part of the esophagus. In that case, PPIs are not very helpful because obviously acid is not the culprit here. Then in some situations, reflux of the acid in the distal part of the esophagus is normal, is not above the normal physiological limit, but esophagus is more sensitive. Even these patients are not going to respond to proton pump inhibitors the way the other patients who have got hyperacidity. So these are the patients where you will start thinking about the alternative options of treatment which may be needed in these cases. So in our patient, we increased the dose. Lifestyle modification was further ensured. Patient came back after 6 months. He's asymptomatic on treatment, but whenever he tries to stop the treatment, he relapses and he wants to be off the drug. You will encounter these patients who are not satisfied with the need to continue with the drugs for years and years. So what are the other options if drugs are not working or the patient does not want to take medication for a long time? One is the option of surgery, and the surgery is basically fundoplication. What simply you can understand is that the fundus is wrapped around the distal part of the esophagus to narrow down that particular passage so as the stomach and gastric content fails to reflux back into the esophagus. There are different types of fundoplications, which basically is the domain of surgeons. Then there is a relatively newer modality. Basically, this is LINX. This is a ring which is passed laparoscopically around the distal end of the esophagus. It keeps this particular end closed and it opens up whenever the food bolus comes down. So there are good results. People are using it and all over the world to manage the patients of reflux disease. Then there is a startup procedure. This basically is a procedure in which you passes a probe down into the distal part of the esophagus, and then there through radiofrequency ablation, you burn that particular part at multiple spots. What happens is that after burning is that because of the fibrosis and scarring, the distal end of the esophagus gets narrowed and the chances of reflux of acid are less likely. So there are different techniques which are being used to help these patients who want to get rid of the drugs. So in short, GERD has to be managed in this manner. The first modality of treatment should always be lifestyle modification, dietary management, and drugs. And obviously, surgery and all other procedures are left for the patients who are refractory or who are not willing to take long-term medications. Now, briefly about the possible complications of reflux disease. Now, this is the barium swallow, and what we can see is a narrowed part in the mid of the esophagus. This basically is an esophageal stricture which can develop because of the long-standing reflux of the acid contents, leading to inflammation, fibrosis, scarring, and narrowing of the lumen. But fortunately, these can be easily managed through endoscopic dilatation, through Savary or pneumatic balloon dilatations. Strictures can be long, but still manageable with endoscopic modality. Then one of the long-term complications of reflux disease is adenocarcinoma. But this is not basically the direct transformation from reflux disease. Adenocarcinoma is the outcome of a long-standing Barrett's metaplasia. So we need to briefly see what basically Barrett's metaplasia is. Barrett's metaplasia is basically transformation of the distal part of the esophagus due to long-standing exposure to the acid. That squamous epithelium starts transforming into the columnar epithelium, but that's basically an intestinal type of columnar epithelium which has got goblet cells. That's what you call as Barrett's metaplasia. So this is what happens. There is no columnar line esophagus, but with passage of time, due to the persistent damage and injury because of the acid, that transformation of the mucosa from squamous to columnar starts evolving. And if this segment is less than 3 centimeters, you call it as short segment Barrett's. If it's more than 3 centimeters, then it's a long segment Barrett's. And there are different ways of describing the length of Barrett's on endoscopy. And this is how it appears on biopsy. You can see on the right side, there is a squamous epithelium, which is normal for the esophagus. But on the left side, the epithelium is columnar. And you can see there are goblet cells as well. And obviously the other features which can, with the help of which we can label it as dysplastic are obviously needs to be noted down to see what is the risk of malignancy in this Barrett's metaplasia. So it's a pre-malignant condition, and Barrett's metaplasia first develops mild dysplasia, moderate dysplasia, severe dysplasia, and then it can transform into malignancy. But this is a process which takes years. So how do we identify dysplasia early? So if somebody have a gastroesophageal reflux disease, we need to have an endoscopy if the duration of symptoms is more than 5 years. And you will always take biopsies from all 4 quadrants. And if there is any abnormal area, obviously you are going to biopsy that as well. Now, how frequently I should perform an endoscopy in these patients, that will depend on the degree of dysplasia in that particular Barrett's metaplasia. If there is no dysplasia, I need to repeat endoscopy every 2 to 3 years in a patient with Barrett's metaplasia. If there is low-grade dysplasia, this interval of surveillance endoscopy needs to be reduced to 3 to 6 months. And now with the availability of a lot of endoscopic ways of resecting the Barrett's and getting this dysplastic area out, people have started opting for definitive treatment even in patients with low-grade dysplasia. And for high-grade dysplasia, you need to proceed for intervention, either surgery or endoscopic intervention. So just to show if high-grade dysplasia, you will confirm it with the second pathologist. You will opt for either endoscopic therapy that includes endoscopic mucosal resection or photodynamic therapy, or you will go for the surgery. Endoscopic mucosal resection is a procedure that is performed during endoscopy. You inject saline below the lesion, raise it up, and then you can easily dissect it out through endoscopy. And this is how it appears. In the picture on the left, you can see that there is an abnormal nodular mucosa, and once it's dissected through EMR, it's almost completely gone. Obviously, you will take out that sample, get it biopsied, and verify that the margins are clear and negative. Photodynamic therapy is another very effective modality of treatment for Barrett's metaplasia with dysplasia, where you are going to burn this whole of the area, which is basically dysplastic, and obviously will follow it with follow-up endoscopies to confirm no recurrence in the later time. So in summary, gastroesophageal reflux disease is basically an illness which is due to the reflux of gastric acid into the distal part of the esophagus. It can present with typical symptoms, but it can have atypical presentations as well, where we have to be more vigilant regarding the possibility of having GERD. Diagnosis is clinical, and investigations like endoscopy, pH monitoring are needed only in selected cases. Major mainstay of treatment is lifestyle modification and drugs to control the gastric acid in the form of proton pump inhibitors. And we need to keep these patients under surveillance for complications, because long-standing presence of this disease can lead to complications like Barrett's and metaplasia. So thank you very much. I hope this session must have helped a lot in understanding the pathophysiology, the symptomatology, how to diagnose patients with reflux disease. And we have briefly covered the outline of the management plan and the possible complications which are associated with this particular disease. Thank you very much.